specifically, I'm going to be talking very much in terms of the practicalities around the ART clinical guidelines. And we're talking specifically the National Department of ART clinical guidelines. Now, the guidelines that the private guys use is the ones printed by the South African Clinician Society. But actually, although there was big differences 10 years ago, in the last 5, 6, 7 years, those guidelines are actually very similar. And there are similar principles and almost exactly the same ARVs that we are using. But we're going to look particularly at what you need to know when you're in a public health sector facility in terms of ART for adults and children. I'm not going to be focusing on pregnancy today because I'll be sending you lots of materials this week on maternal health, but we're only going to be focusing on the pregnancy maternal health side, PMDCT next week, and I'll send you some nice webinar links for that. So what I thought I'll start doing is I'm going to do 4 slides. It's going to cover the whole guidelines and all the key things that I think you hopefully already know. So some of you might already have recently been running a impressive HIV program at a local regional hospital, and you know the HIV guidelines inside out. But it's more likely that if you've just come from a big regional hospital, that you might have done a little bit of HIV in the ward, but you haven't actually had much experience in sitting in an HIV clinic seeing patients. It's very important when you're in a district health setup that you understand the ARV guidelines very well. Even though our clinics are actually implementing the guidelines, the district hospitals and the doctors are sort of the ones that pick up the slack with any of the problems that the clinics are experiencing. And starting off, of course, the most clear, obvious thing that we all know at the moment is we have this new amazing combination tablet, tenofovir, 3TC, dolutegravir, the new baby on the block. And the basic principle is that any patient who's newly diagnosed with HIV is going to be starting on that regimen. And I will talk about women in childbearing years in a minute. And just note there as well that this is, of course, also true for mental health patients. So dolutegravir is much gentler in our mental health patients than efavirenz was. And therefore, you will no longer see nevirapine in the guidelines at all. Dolutegravir can still cause a bit of insomnia. So if you've got patients with anxiety, for example, that's struggling, you are going to monitor, but TLD has become pretty much our across-the-board ARV, and we will talk about women in a minute. So the principle now as well is that as soon as the HIV is diagnosed, you start. In the old days, we had these long preparation processes. If your patient's ready and they're reasonably well, we'll talk about the provisos just now, you're going to start them on the same day. If they're not completely sure, or if you still need to sort out a few clinical things, then you can start them within 7 days, but we don't try and delay at all. And so they have to be very well, they have to be ready. And they have this thing, you mustn't suspect renal abnormalities. It's very uncommon that you're going to have a patient where you're going to be worried about renal unless they're really sick. And then just remember there's a few exceptions. So anybody where you're suspecting meningitis or has been diagnosed with TB meningitis or cryptococcal meningitis, we're going to wait at least 4 weeks, 4 to 6, 4 to 8. And if they are CLAT positive, we're not going to start them on the same day. We're first going to give them 2 weeks of their fluconazole. Or if they've got MDR TB, we also wait 2 weeks, but no longer than that. So just note that's a bit shorter than we used to. And of course, if they've got drug-sensitive TB, we'd like to start the TB treatment first. And they still have in the guidelines where they have, if the CD4 is under 50, you start within 2 weeks. And if the CD4 is over 50, you can start within 8 weeks. I don't think we ever wait for 8 weeks to start somebody on ARVs. In practice, mostly we start people within 2 to 4 weeks after starting TB treatment. And there's just a nice quick summary of what baseline tests you need to do. So on the day that you're starting your ARVs, you obviously want your CD4. They'll do a reflex crag for you at the lab if the CD4 is under 100. You want your hemoglobin, you want a creatinine because you're going to put them on tenofovir, and you do hepatitis B. If they've got any TB symptoms, you need to do a gene expert. We're not going to talk about pregnant women here. And cervical screening where relevant. So these days with HIV patients, they get their cervical screen every 3 years. So just check where they are within that cycle. But very important, if your patient's very sick, they do need to be properly worked up before you decide what you're going to do with the ARVs. And if they have a CRAG positive, even if they're well, or any meningitic symptoms, it's now recommended you do an LP. So in the old days, we tended to, if they were asymptomatic with the crags, to start the fluconazole, but now you actually want to LP them. We've been missing quite a lot of meningitis. The YouTube link there is on my YouTube channel. That will also come in your resources. And that's a specific tutorial on working up the very sick immunocompromised patient. I'm just going to ask, please just mute yourselves. Thank you. Perfect. Usually when they've newly arrived. Oops, sorry. I'm doing this on my own. There we go. So let's just quickly talk about prophylaxis. If this has also changed, so not everybody's always aware of that, any patient with a CD4 is under 200 or 25% in our under 5-year-olds, or if they're symptomatic of HIV, so good old-fashioned WHO stage 2, 3, or 4, we're going to give those patients cotrimoxazole. The change there is that at one stage it bumped up to 350, but they've brought it back down to 200. And once the CD4 is over 200 and the patient is well, then you will discontinue your cotrimoxazole. But also very important is to give iron H to all our new patients initiated on ART. So this is also new. That it used to be quite complicated. You'd have to do MAN2 tests. And now it's just simply saying, as soon as you put a patient on ARVs, you're also going to start them on iron H. Of course, they mustn't have any contraindications to iron H, such as liver disease or severe alcohol use. And of course, they mustn't have active TB. The only exception here, and that is more in the PMTCT presentation as well, as our pregnant women. So in pregnant women where there's a CD4 over 350, we don't like to use iron H in pregnancy, and you're going to defer until 6 weeks postpartum. And remember, the iron H always comes with pyridoxine. So the other thing that's different is in the old days, we used to stagger these things. You know, you'd start your ARVs and then you'd start Bactrim, and at some point you'd start the iron H. This is going to be one script on the day. You're going to prescribe your ARVs, you're going to prescribe your Bactrim, you're going to prescribe your iron H and your pyridoxine. And actually the tablets these days has got so few side effects and so few complications that we're quite comfortable giving all of those at the same time. So here's a very quick summary on second-line therapy. So we now have different scenarios depending on what people are on when they fail. Just a quick reminder, biological failure, anybody who's biologically failing, you want to do your ABCD. You've been in the Eastern Cape for a while, would have all have heard about ABCD. So adherence, checking that adherence is good. B stands for bugs, making sure there's no other opportunistic infections. C stands for correct dose, making sure that the child's on the correct dose for weight, or if they've been a renal patient, it's been adjusted, or if they're on TB, it's been boosted, etc. And D for any other drugs that might be interfering. I'm just going to mute here. There we go. Great. So there's difference. Well, the challenge of the current guidelines is the fact that we're sort of in a in-between time where some of our patients are still on the old ARVs and some of our patients are on the new ARVs. And if you remember from the old ARVs, most patients would have been on tenofovir, metrocipetabine, and efavirenz, the so-called fixed dose combination. And the definition for failure is still the same. Your viral load is over 1,000 on 2 occasions and you're out. But we're using a new second line. So that lovely new second line, AZT, 3TC, and dolutegravir. We really like it. It's tough. The dolutegravir is a very powerful drug, and it's not that many tablets, and we don't have all the side effects of Illuvia. So this has brought in a new era for us in terms of going on to second line quite happily. And just here, just note, if they're hepatitis B positive, then you add tenofovir to that regimen just to be able to cover your hepatitis B. But now we have patients we're going to start on tenofovir, lamivudine, and dolutegravir, our new first line. Now, this first line is tough. It's not easy to break dolutegravir, although I'm sure we're going to try over the next few years. And therefore, the definition for viral load failure is very different. Your viral load has had to mean over 1,000 at least 3 times over a period of 2 years. So we're expecting probably there's not many patients who's actually been changed to a second line yet on a dolutegravir-based regimen because it takes such a long time to fail on it. So that's quite exciting. It's one of the reasons why we like TLD. But if they fail on TLD, they're going to go on the old second line that we know, AZT, 3TC, and lopinavir ritonavir. This is one of those little interesting little details here. But these patients, if they're hepatitis B positive, we're going to use tenofovir, 3TC, and lopinavir ritonavir. You'll notice there it's just the 3 drugs. We dropped the AZT. The reason why we do that is there's a lovely trial that's already came out quite a few years ago showing that lopinavir ritonavir in combination with other NRTIs compensate any mutations. So when you have a mutation against tenofovir or AZT, you can still virally suppress beautifully. And therefore, if they need that tenofovir, we can get away with a tenofovir, 3TC, lopinavir, ritonavir regimen, even though there might be mutations against the tenofovir. So just to notice that difference. Dolutegravir, we don't know. We don't know if dolutegravir is tough enough to cover for other mutations, and we don't like to risk it. And so if they've got hepatitis B positive, but you're putting them on second line with dolutegravir, you're going to have to add tenofovir. That's one of those little interesting phenomenon. So that's our 2 main second line regimens now. And if anybody fails on any of those 2 second line regimens, so you note that this is their second line that they are taking, you have to do a resistance test. So still going from first line to second line, you don't need to do a resistance test. But when you want to go from second line to a possible third line, you need a genotype, whether they failed on the dolutegravir or failed on the lopinavir ritonavir. To do that, on the NHLS form, you turn it over to the back. Yeah.
Many people from other provinces join.
Apologies. I am both hosting and teaching. Great. So the way you do that is you look on the back of the NHLS form. There's a whole little bit on drug-resistant TB testing. Just fill that in properly. And then you have to submit 4 purple top tubes with that form. And once you've got your genotype result and the patient is resistant to one of the PIs or to dolutegravir, then you're going to have to send that form in to the third line committee. And for those of you on the Rural Onboarding course, I would have already sent you the link to that form. Otherwise, you can go and look it up on the Clinician Society website. If you just Google third line form, you'll find it very easily. And on the form, you have to fill the form in with all the past history. And then there's an email address that you send that to. When you send it to the third line committee, remind them they're a virtual committee. They're not people who actually meet in a room. They meet virtually. And I know sometimes there's delays in hearing back from them, but they're all very willing to help. One just sometimes have to prod a little bit. And then a quick slide on just the monitoring once our patients are on ARVs. Remember, always weight growth, very important neurodevelopmental assessment in our children. Obviously, we're going to screen for OIs and TB at each visit. And then in terms of your blood, so your viral load still at 6 months, 12 months, and then annually, as long as it stays under 50 LDL. Our CD4 count at 12 months on ARVs, so you don't do it at 6 months. And the reason why you're doing the CD4 count is to decide about Bactrim. So if the CD4 is still under 200, you're going to need to keep your Bactrim going. And then you're going to keep on doing your CD4 every 6 months until your Bactrim is discontinued. But as soon as your CD4 is over 200 and you can stop your Bactrim and your viral load is under 1,000, you're no longer going to monitor CD4. For patients on tenofovir, we're still monitoring the creatinine 3 months, 6 months, 12 months, and annually. And for the PI regimens now, you just do a cholesterol and triglyceride at 3 months. So if somebody's going to react negatively on a cholesterol level on their PI, it's usually soon after starting treatment. So you'll check at that point. And if they're going to be on AZT, if they're on second line, you do a full blood count and diff at 3 months and 6 months, and after that, clinically. So that's just a very, very quick slide on what I hope you already know. Great, but now we're going to get to some of the more interesting little ins and outs of the guidelines. Just covered all the boring bits, right? And the thing that's always very confusing is the whole story of dolutegravir and women wanting to conceive. So this is our typical dilemma. We've got a lady who arrives, MN, she's 23 years old, she's presented at the clinic for a pregnancy test. She's been on Depo-Provera, but her last injection was 6 months ago because it doesn't look like in COVID anybody got their Depo-Proveras. I'm seeing a lot of COVID baby pregnancies at the moment. And her pregnancy test is negative and she's disappointed. So she's obviously trying for a baby, but she's in the clinic. So the nurse counsels her, do a HIV test, which turns out to be positive. So the nurses counsel, they take all the necessary preparation bloods, they're getting her ready to start her on ARVs. And now the question you get asked by the clinic is, which ARVs do we give now? And what would we advise her regarding pregnancy? When should she fall pregnant? Now, there's been a lot of changes in the last 2 years, and it's actually one of the biggest reasons why the rollout of dolutegravir got delayed, probably by a good year. We were just about ready to give it to everybody. And then a Botswana trial came out called the Tepamo study. And it was actually a study that was looking at not just dolutegravir, but women on all kinds of ARVs. And they were looking at what would happen if women fell pregnant on ARVs. And one of the things they looked at specifically was congenital abnormalities. And so early on in the study, when they still did not have very many numbers of women falling pregnant on dolutegravir, there was a scare in terms of a risk of neural tube defects. Now, even then, we knew that the study was not big enough to not enough power to tell us if that was actually a true result, but the WHO didn't want to take any risks. And so just before we rolled out in 2019, April, with the dolutegravir, there was a huge announcement by the WHO, a warning saying, we don't know, there might be a risk of increased neural tube defects if you conceive on dolutegravir, and therefore it was recommended to not prescribe it for women in childbearing age. And that threw a real spanner in the works. We had to rewrite the guidelines. And you will see when you look at the guidelines in the last 2 years, there's several updates that keeps on being brought in as new information has been coming out. The Tepamo trials, the Tepamo study has finally been completed, and we have much bigger numbers. But it's also important to realize is that there was no folate supplementation in Botswana. So there's generally been a higher incidence of neural tube defects. But in that study, there was an additional 2 neural tube defects per 1,000 when you compared dolutegravir to efavirenz, which is a very small risk. If you look in terms of the worldwide numbers that we have, and you include what they then did is they did large meta-analysis and looked at a woman conceiving on dolutegravir right across the world, this finding wasn't found in any of the other studies, probably because most of those countries have got folate supplementation. So with all of this in mind, the WHO then finally at the IAS, the last big AIDS conference, brought out, I like the article was after much hand-wringing, a reassuring guidance that dolutegravir is recommended as a first and second line antiretroviral treatment across all populations. So the WHO has sort of made a blanket, it's fine, we can use it in women who want to conceive. Countries has still been nervous in terms of how to adopt this and how to counsel women on this. So both in South Africa and Britain, for example, we have this concept that what you're supposed to do is counsel women and give them the option. So we still have in the guidelines a caution for women trying to conceive, and it's only really to do with that first 4 to 6 weeks of pregnancy. So once a woman is pregnant, we're very happy to use dolutegravir. It's just when they're trying to conceive where it's an issue. So what the guidelines recommend is you're supposed to sit down for the woman and go through the benefits and risks of using dolutegravir versus the benefits and risks of using efavirenz. Now, I have to say, for most of our population, this is a very difficult conversation. When women are trying to conceive, they are obviously quite emotional and trying to explain to them there's a very, very, very small risk potentially to the baby, which might not even be there. It's a difficult conversation. We do like dolutegravir, and if we could, we would like to give it because it is such a powerful drug, especially in women once they're pregnant. It's so difficult to break. It's got this high genetic barrier to resistance. It's got less interactions than efavirenz does. And so generally, we have a tendency to like moving towards dolutegravir. What's happening in practice is that if you've got a woman like this girl who's actively trying to fall pregnant, you're probably going to end up still using TEE. So you're still going to use your efavirenz-based regimen unless you've gone through all of this with a woman and she's decided, no, actually, she would rather want the Dolly Tag. But I think in most of these cases, our advice will go more towards the TEE. But if you've got a woman who's just in childbearing age, not planning to fall pregnant at the moment, thinking about contraception anyway, it's very valid to still have the discussion, but you're probably going to be easing her towards the Dolly Tag side of the conversation. So this is an interesting dilemma that we face every time we have to counsel women who we're going to start. In certain scenarios, like with MDR-TB, efavirenz interacts with bedaquiline, so we don't like using efavirenz. And we tend to ask our women to not fall pregnant while they're on the MDR-TB treatment, which is not not advised anyway. We recommend contraception, and we basically always use a Dolly Tag-based regimen. So that's a good example of a place where you, as a healthcare provider, might be swinging the woman more towards the one direction. The most important thing is that you just have to have a conversation, a record that you've had that conversation. And I think the big worry is that medico-legally, of course, with all ARVs, with all women, no matter if they're in medicine or not, might at one stage have a neural tube defect. And the worry is always if there's some concern that it could have been caused by the Dolly Tag. So just have a note in your, you don't have to necessarily have a consent form, but you do need to have a note in your clinical notes that you've had this conversation. This is probably the most controversial part of the whole guideline. And so I would like to open now if there's any comments or questions at this point of the presentation. I'm going to see if there's any hands. Okay, I think we all equally. So let's then move on and looking a little bit, the big challenge with the new guidelines is the new guidelines are actually quite straightforward, but the problem is we're now in this transition phase. And I think initially there was a hope that we were going to move very quickly from the efavirenz-based regimens to Dolly Tag, but partly because of our childbearing woman population, and partly because at one stage last year, they ran low on stock of TLD, and every now and then the program is being slowed down a bit. So at the moment, we have a huge mix of patients on either efavirenz-based regimens or Dolly Tag-based regimens, and we're still in the process of handing people over. So let's just talk about what's easy and what you already know. So the easy switch is patients who are on tenofovir, imitricitabine, efavirenz combination. Viral load is LDL in the last 6 months. It doesn't have to be more recent than that. You can just happily change them to TLD. Now you will notice that programmatically there's a huge push to just get that done, to get people onto TLD. There's just a word of caution here, is that it's actually quite controversial whether we should just switch people regardless, even though TLD certainly is a better drug, certainly has less side effects, and certainly is more powerful. There is a debate that if you've got somebody who's, say, been on TEE for 3-4 years, completely stable, has no side effects, viral load is LDL, whether we should really push them to TLD. Because remember, what's going to happen is that there's a chance that when they go into Dolly Tag, they might even develop new side effects they haven't even had with the efavirenz. It's one of those things, there's been some lovely debates at the infectious disease conference on how vigorously we should take very stable, very happy people on TEE and put them onto TLD. The big thing why there's a programmatic push for TLD is that it's cheaper. So there is definitely going to be a push from government side to change everybody. I'm just going to ask again, just to mute yourselves if you've just joined us. Thank you very much. That just helps for the interference. Great. So if you've got a patient who's now on TEE and you do the viral loads and the viral load is over 1,000, then you're going to be following your guidelines for viral load failure. Just if I can mute that. There we go. Sorry. So now you've got a patient on TEE and they're here for their routine viral load check, and that viral load shows viral load over 1,000. We're going to now aim for, what are we going to do? Is this possibly viral load failure? you're going to recheck the viral load in 3 months. And if it's still high, you're going to switch to second line. So those patients we're going to not put on TLD, and they're probably going to end up on the new second line. But there's that in-between group. When the viral load is between 50 and 1,000, then we want to recheck it in 3 months' time. And if it's still under 1,000, we can consider changing to TLD. That's how they put it in the guidelines. I personally would like the viral load closer to 50 than to 1,000, and we're not really in a rush. So if the patient's very stable on TEE, you also can check the viral load again in another 3 months. If it's one of those viral loads that's always hovering around 200, 300 patients otherwise very well, you could potentially consider switching to TLD. So in the guidelines, there's a nice algorithm, but the only ones we switch without thinking is the ones where the viral load is suppressed. Very important. So let's make this a bit trickier, right? Still boring. Okay, now, now we've got all those patients, especially now after COVID, right? 22-year-old male patient, started on TE about 18 months ago. After 8 months on treatment, he defaults. His 6 months viral load, so just before that, was 8,345, and there's some notes that there was adherence issues. And now he returns because he's sick. He's got oral thrush, he's got a weight of 48 kilograms, his CD4 is 56. The nurse in the clinic has already done a gene expert, which was negative, but he's had a bit of a cough for the last few days, and his COVID was negative as well. So now what do we do with the ARVs? So he used to be on the old regimen. And when would we start the ARVs in a patient like this? So let's just look at first principles after treating somebody that's been lost to follow-up. So this is somebody who was on an efavirenz-based regimen and now comes back. And the bottom line here is we are very precious about dolutegravir. We know dolutegravir is tough, but we don't want to risk breaking this brand new drug. We'd love for our patients for dolutegravir to be on a first-line regimen for years before we have to start worrying about changing them. And the rule at the moment is that whenever we put somebody on dolutegravir, they have to go with a nice strong okay, there we go. So as a general rule, you want to make sure that you can't risk putting the patient with an NRTI that might not be 100% functional. So if there's any chance of resistance to your NRTIs, you're not going to use a dolutegravir-based regimen. So the rule is if somebody has been on one TFE or any drugs that they've been on ARVs and they've defaulted, start them back on the same ARVs so we can almost do a little trial. So if you look at the ARV regimen and you go, I think this patient, maybe that ARVs might still work. I'm going to give the original regimen and then I'm going to repeat my viral load 3 months later to see if that regimen is still actually working. The other option, of course, is you look back in the notes and you notice, no, man, this guy was on treatment for 4 years. His viral load was always suppressed. He was obviously never taking his treatment. And then you're rather going to put him straight on the new second line. And remember, we like the new second line, not that many tablets, nice and tough. So it depends a little bit on what happened before the patient defaulted that'll make you decide what you're going to do. So say, for example, our patient was on ARVs for less than a year, then the TE might still be functional, right? And so we're going to restart that old-fashioned tenofovir, metrocitabine, efavirenz that we used to be on, but you recheck the viral load after 3 months. And if the viral load is no LDL, it means great, that tenofovir is working beautifully, I don't have to worry, and I can change my patient to TLD. So there's an in-between step for patients who's defaulted on treatment. And you don't want to just go straight onto dolutegravir. Now let's take the scenario and change it slightly. And you've got a patient who was on second line treatment and then they defaulted. So for example, the one example I've already given, is the patient who's defaulted on, who was on TE for years, but the viral load was never suppressed. So those ones you're going to put straight on second line, the new second line, AZT, 3TC, and dolutegravir. But what if my patient was already on AZT, 3TC, and Eluvia, but defaulted treatment a year or 2 ago? And very important here, there's not an option at this point to change from the old second line to the new second line. And the reason why we do that is that we don't know if there's a mutation against the AZT. So I've mentioned earlier, even if you've got viral load suppression on the old second line, that Eluvia might be so powerful that it's covering that AZT and 3TC mutations. Alluvia has that possibility that comes out of the EARNEST trial. We don't know if Dolly Tag can do the same just because we haven't tested it. So we don't want to risk putting the Dolly Tag with the AZT if we're not sure the AZT is 100% functional. And therefore, there's no possibility to switch people on the old second line, even if they're virally suppressed, to the new second line. So just to be aware of that, that's different than our first line. But now, how soon do I start this particular patient? Because remember, I said this patient's sick. He's had a bit of a cough, he's lost weight, he's got 2 of the 4 TB screening symptoms. And now you say, but hold on, gene expert was negative. Please remember, your gene expert does not exclude TB, especially in our patients with HIV. You might have extrapulmonary TB, so then you'll just see the weight loss. Might have hilar lymphadenopathy in your children, then you won't find anything on a sputum. Or you can get gene expert negative pulmonary TB. So these patients you have to investigate further just to double check if there is TB before we put them on the ARVs. And there's a couple of things you can do. So I haven't actually got a slide on it, but just remember LAM. Some of you might be aware of urinary LAM, especially if you've been in FRERE or CMH, where they've been trialing the urinary LAM. So that's a dipstick test that tests for some of the pieces of the TB bacilli. And it works particularly well in patients who are HIV positive and where the CD4 is under 200. It's one of the few places where a test works better because the patient is immunosuppressed. So it's not very useful in our HIV negative patients, unfortunately. But in a patient like that, when you're struggling to get a sputum, do a urinary LAM dipstick. It unfortunately doesn't tell us whether there's resistance or not, but it will tell us whether there is TB. Of course, the X-ray can be very useful to pick up your lymphadenopathies, some of your TBs that is not cavitating. And then there's things that can give you a clue. So your full blood count, you often have an anemia if they've got severe TB. Your liver function tests might show an increased ALP and gamma GT. If you've got access to an ultrasound, even better. CRP, not very helpful, but if it's very high, it does give you a clue. So you're sort of putting a whole lot of investigations in a pot. Give a course of antibiotics at this point. He does have a cough, and review after 1 week. What will happen now is he's either going to develop more symptoms, or you're going to find things on your tests that's going to give you a strong suspicion of clinical TB, and then you will start TB treatment. Or you're still not sure. Doesn't matter if you're still not 100% sure. If you don't have enough evidence to make you convinced that there might be TB, just start your ARVs. And so you will start your ARVs then within a week after the HIV diagnosis. If you're not starting ARVs, but your patient is still symptomatic, at this point, you have to think about what you're going to do about TPT, about your INH prophylaxis. We don't actually want to give the patient INH if the patient is still symptomatic. So if he's still coughing's a bit better, or let's say the cough has settled completely after your antibiotics, your X-ray is clear, your liver functions is clear, then maybe you can just start your INH, and you're going to give it for 1 year, remember. But if your patient's still coughing after that 7 days, you're not convinced it's TB, but you're not completely unconvinced it's not TB, you're going to start your ARVs and you're going to watch that patient. And if there's TB there, they'll iris. So the diagnosis will become clear soon enough, and you'll watch them for a month. If after a month your patient is now gaining weight, the cough has settled down, then you can start your INH quite safely. I think this is probably a good point to look if there's any questions or comments on this case that we've just discussed in terms of transitioning patients from the old to the new regimens. Let's see if there's any questions. Okay, and please just mute yourselves if you're new on there. Also, while we're taking a breath, please introduce yourselves in the chat, just who you are, where you're from, what you are doing. If you would like more information about the Rural Onboarding course, just give me your email address. Great, we're going to continue. I hope none of you are all asleep. So, okay, let's talk then now about transitioning. We're still talking about changing regimens, but let's also just talk a little bit about our children regimens. And our children care has become actually much easier with some of our new options because we can use dolutegravir from 20 kilograms. So we can actually use in quite young children. And what you need to be aware of is that there are 4 different regimens depending on the age of the child. And I think I'm not going to spend too much time on this because if you do see a child with HIV, please go back to your guidelines because you're not going to see many children with HIV. One of the extraordinary things of the PMTCT program is how few children we now see coming through with HIV. But if children do get HIV, they're going to end up at your door. And then go back to your guidelines and go and look up to see what they are. Okay. I'm just trying to mute people. Sorry. Great. So let's start looking at our regimens for children. So just to be aware, if a neonate is diagnosed and they're less than 28 days, or if they're still less than 3 kilograms at 28 days, we're going to use AZT, 3TC, and nevirapine. There's little provisos depending on their gestational age, etc. So you're going to go and look this up. Just to be aware, that's your regimen for the first 28 days. We can't use Eluvia or abacavir. But as soon as they're over 3 kilograms, and as soon as they between 3 kilograms and 20 kilograms, and they're more than 28 days in age, we can now use that. Remember that old-fashioned ARV regimen we all know for children: abacavir, 3TC, and lopinavir ritonavir. But once they're over 20 kilograms, but they're still under 10 years old, so usually they'll still be under 3 by the time they've reached 20 kilograms, you can now switch them to abacavir, 3TC, and dolutegravir, using the same rules as we did before. We want that viral load to be LDL. But we can start using the dolutegravir, and it's lovely because abacavir, 3TC, we've got small tablets, combination tablets are coming out more and more. Dolutegravir is once daily, and we're able to give them a much easier regimen than the lopinavir ritonavir regimen. And then finally, once they're over 10 years old, that's also changed, it's a bit younger, it used to be 15, and they're over 35 kilograms, we can change them to the new TLD tablet, tenofovir, 3TC, and dolutegravir. And that is a great option for our teenagers to be on that one tablet from quite young. What I want you to notice is that you should be able to move between these regimens. So if a child was on abacavir, 3TC, and lopinavir ritonavir, if the viral load is LDL, you're going to be able to move them up, move them to these new regimens. And I just want to give you a couple of examples. So this one scenario is you've got that child who was started when they were really, really little on abacavir, 3TC, and lopinavir ritonavir. Now they weigh more than 35 kilograms. They're just over 10 years old. The viral load is LDL. They're doing great otherwise. A child like this, we can now already change to the TLD. So to the one tablet once a day, which is a great option already at this point to get them off that Eluvia. The second scenario is a little bit more controversial. But I'm just going to talk you through it. So imagine you've got a child who was started on abacavir, 3TC, and efavirenz when they were 5 years old. Now they're age 9 years old and they failed, biologically failed, and so they were changed to the old second line, AZT, 3TC, and Eluvia. And you might still have issues because you're struggling with them with the adherence on the Eluvia. The AZT is twice daily, it's massive big tablets. And what one can do in this scenario, and there's a little proviso, it's like in the small print in the guidelines, is that you can make a case for TLD. The guidelines say probably discuss, so just talk it through with another colleague, just look at the whole scenario. Because if you think about it, this child has never been exposed to tenofovir or dolutegravir. So we know that tenofovir is still safe. If the tenofovir is still active, this can partly protect the dolutegravir. So we still have that strong NRTI. The reason why it's not an automatic, oh, sure, let's just use TLD, is because there's always a small chance of mutations, cross-resistance between abacavir and tenofovir. The risk is not very high, and this is one of those harm-benefit ratios. So this is where the guideline says, because of the massive adherence advantage to giving just this once daily dosing to somebody who's been struggling on both failing on their first or second line, we can give our teenagers TLD. So just to keep that in mind, the only proviso is they must not have been exposed to tenofovir before, but we're going to forgive them for having been exposed to the abacavir in the past. Great. So that's quite an interesting in terms of getting our children onto nicer regimens. At this point, are there any questions? Anybody would like to ask? Checking if there's hands. Gosh, excellent. Swiftly moving on. Time-wise, yes. So we all love dolutegravir. We all keep going on about dolutegravir, but unfortunately, dolutegravir is not all roses. And there are a few irritating interactions that one needs to be aware of. They're very nicely outlined in the guidelines. I've got beautiful, huge tables. But I'm just summarizing it a little bit from a practical point of view of what you're going to see in the consulting room. So firstly, just remember, if patients have got TB and specifically rifampicin patients, then we have to double the dose of the dolutegravir. So unfortunately, the rifampicin reduces the dolutegravir dosing slightly. And so what will happen is they'll take the TLD once a day, and then if they take the DLD at night, then they'll have their 50 milligrams of dolutegravir in the morning. So in the guideline, what they say is if you're starting a patient newly on TB treatment, you might decide to rather give them the TEE because it's still just a once a day dosing. And we know it's still a lovely regimen. So it's appropriate if there's no contraindications, they're a new patient, you've started them on TB treatment, you can still use TEE in those patients. And then once they finish their TB treatment and their viral load's LDL, then you can move them to TLD. But just remember if they're on rifampicin to boost them. We notice those slip through definitely. The other issues are pregnant women and supplements. That'll probably be covered a bit in the PMTCT guidelines as well. So dolutegravir interferes with various ions, including iron and calcium. So all of our pregnant women are on iron and calcium, and you can't give iron and calcium and TLD on an empty stomach. Okay, not good. And you can't give iron and calcium together, so it's enough to do your head in when you try and prescribe. To make it very simple, in the evening, if you're going to give them their ARVs in the evening, just give them their ARVs, their TLD with food, with their calcium, and then get them to take the iron in the morning. But that's also something you can look up. Just to remember supplements and dolutegravir. But just like iron and calcium can get affected by dolutegravir, so can aluminium and magnesium. So watch out for your antacid. So this is the guy who's popping all those Rennies or using just some of those over-the-counter Gaviscons and related antacids. And if it's got aluminium or magnesium in it, they're not allowed to take it at the same time as the TLD. So check for your patients what other over-the-counter stuff they might be using. And then remember your epileptic patients. So unfortunately, just like efavirenz, there's also interferences with dolutegravir. Very similar. It's also none of the only safe ones that you can use that we have in the public sector is either Epilim, or you can use carbamazepine, but then you've got to boost the dolutegravir. But remember, please, you can't give Epilim to women who are pregnant or are going to fall pregnant. It is very teratogenic. And so if they're childbearing age, ideally we should be using lamotrigine, or if you don't have lamotrigine, you could use carbamazepine if you're boosting your dolutegravir. So that's one of those important things, or we're going to run into trouble later down the line. And then there's this interesting little proviso around diabetic patients. So dolutegravir boosts metformins, right? So your metformin dose is going to be much higher in the body than the dosing you're giving orally. That makes sense. So in the guidelines, it also says you have to use no more than 500 milligrams of metformin twice a day. So now imagine you've got that patient, we've had these. They come in, they're on their metformin 850 twice a day or 3 times a day. They've got a HbA1c that's already up. You would have to actually reduce that metformin dose to 500 milligrams BD, or the patient's going to be developing some of those horrible metformin side effects and is going to be at a higher risk of acidosis on that metformin. So what it means is, although you're giving metformin 500 milligrams BD twice a day, he's already on the maximum effect that the metformin can give him. So you're still going to have to manage him as you would have managed somebody who's on maximum doses metformin, but the HbA1c is not controlled. So you're going to have to look at your sulfonylureas. You're going to have to relook, obviously, at your diet. And if need be, you might have to add in your insulin at that point. But this is one of those things that slips through. And to make it slightly more complicated, one of the side effects of dolutegravir is definitely a little bit of gaining in weight. So the average is about 3 kilograms of gaining in weight, but that's an average. There's a bit of a wide confidence interval. And every now and then there's been some lovely dramatic stories of 10, 12 kilograms gaining of weight. Now, that's very fine if you've got one of those underweight patients, but it's a real problem if you've got a patient who already have metabolic syndrome or already has diabetes. So in the guideline, they actually say if you've got an overweight patient, which would be BMI over 25, you might have to consider TEE, and you have to give people all kinds of dietary advice and tell them to lose weight and warn them to be sensible with what they eat, which, as we all know, is a difficult intervention if somebody doesn't have a real motivation of why they need to lose weight. Because dolutegravir is still new in the mix, we're still waiting to see of how much this is going to be an issue in our population. And it is something you have to counsel your patients about, especially if they are weight aware or if they've got high weight and there's a health risk to them gaining more weight. I think we can, yes. So we're at 5 to 7. I can decide how much of the renal one I'm going to do. Any questions at this point regarding some of the cautions and some of the contraindications for dolutegravir? Cautions is a better word. Let me just see if there's any hands. Oh, look, there's a hand. Yes, Mr. Ongole, do you want to unmute yourself, Ongole?
Yes, Madeline, I've unmuted, but I also sent the questions on the chat.
Oh, sure. Thank you. I'm presenting answer. I'm struggling to read chat as yes.
Okay. The question is the patients, the diabetic patients who are using the new drugs, the guidelines, which is empagliflozin.
Yes.
Do you need any dose adjustment at
Not
this
as far
point?
as I know. Yeah, I actually looked that up. At the moment, the only one they're mentioning is metformin. It's always a thing with drugs that's new. Well, that's that new in our populations where the things might still come up. But the only caution that I've seen is on the metformin. So we might end up relying a bit more heavily on the sulfonylureas in those patients and the insulin. But the idea is still that you're still getting the maximum benefit of the metformin. You're just prescribing it in a lower dose. So that's the theory. I don't know with our very overweight patients. Yeah.
Okay, thank you. Thank you very much.
No problem at all. You can just mute yourself again there. And then I will check all the chat for questions at the end. So we've actually booked the session for an hour and a half, but I know that by an hour, people start feeling slightly, especially with it's a very didactic lecture, this, isn't it? It's not that, not too many fun stories. But the one issue that comes up a lot in terms of ARVs in general, the only complication we really have that we probably need to talk about is renal. So if you think about it, in the old days with stavudine, we had all these metabolic complications and we had all these, bodily problems with lactic acidosis and, but these days actually our ARVs are surprisingly easy to use. But the only problems that we are seeing is sometimes with renal function. So I've got a few slides on renal function. I do realize we are getting towards 7 o'clock. If you need to leave because you've got something else, well, you just need to go and have your dinner. You're very welcome to. It's going to be recorded and the whole presentation will be available and will be distributed. If you're not on my normal database, then you just need to send me your email address. Otherwise, I'm just going to cover a few slides on renal dysfunction and patients on ARVs. So we're going to go through 3 scenarios at the end, but I'm going to cover a little bit of theory first. And the one scenario is your patient who comes in already with a disturbed renal function. The second scenario is a patient who's on TLD, who comes in sick, admitted with COVID in this case, whose creatinine is high. And a third scenario is a patient who is oh, where's my slide? There we go, who's healthy and well, and then suddenly their creatinine goes wayward. So the first thing to remember is that tenofovir-induced nephrotoxicity is very rare. And one of the challenges that we have is that in the clinics, quite often it's just assumed. They will see the creatinine is up. They will go, oh, it must be the tenofovir. They'll stop the tenofovir and put the patient on a bacavir. And then that's where it stops. There's no further investigation. So any patient where the creatinine is up, you actually have to investigate to find out what's going on. The second thing that makes it a little bit more interesting is the Dolly Tag actually decreases the tubular secretion of creatinine. Now, this is not a problem. It's not actually damaging the kidneys. It's not damaging the little glomerulus where it's filtrating. It just has an effect on the creatinine pump, so to speak. So in a lot of patients, the creatinine might increase by as much as 15% without reflecting on the kidney function at all. So it's like a false increase of the creatinine, and certainly not a reason to stop the tenofovir. But it's going to make it confusing if there's other renal adverse events going on at the same time. What's much more common is acute kidney injury. So a lot of our HIV patients get sick. They get sick with infections, they get dehydrated, they don't eat properly, they get oral candidiasis and don't drink enough. And they come in with a creatinine is up, and you put them on a bit of a drip and a bit of Bactrim and some AR, and they do wonderfully, and that creatinine normalizes. And that's the vast majority of cases. And what we don't want to do is mistakenly diagnose somebody with a tenofovir nephrotoxicity when it's actually just an AKI. And then the other thing we're seeing more and more now, because we've got so many patients that we're starting on HIV treatment, we've got lots of patients with comorbid disease. So there's a lot of patients with chronic kidney injury due to their cardiovascular disease, their high cholesterols and their high sugars and their high blood pressures. It's got nothing to do with their ARVs. So again, we want to be able to tease this out properly when we see an increased creatinine. So when we measure kidney function, now this has also changed over the guidelines over the years. They made it quite complicated when we first started, in that we had to do all these fancy calculations. There's different calculations to tell us how renal function is working. Because remember, creatinine is just a metabolite that we excrete. It's made by our muscles, and we just excrete it through the kidneys. And it's just easy to measure. That's why we use it to tell you how well your kidneys are working. The problem is that it's got a different set of normal values depending on if you're male or if you're female, or if you're old or if you're young, if you're big and muscly or if you're small and thin. And so we always have to use this GFR to tell us how well it is actually working. We actually have to adjust the creatinine for age and sex and all of that. So there's lots of different formulas. And in the latest guideline, which to make it easier, they now use the MDRD formula as a reference, which is the same one the NHLS uses. Matter of fact, they print two for them. You've noticed we've got two GFRs now that they measure for us. And that does make it a little bit easier. You can actually just look at your GFR result on your creatinine measurement. So here we've got a lovely table. It's in the guidelines. And I just want you to show you there's slightly different formulas depending on the age. So if they're more than 10 years or less than 16 years of age, we use this lovely Cunahan-Barrat formula, my pronunciation. And just notice that we expect the creatinine clearance in children to be much higher. We don't expect there to be much assault on those kidneys yet. But once they're adults or adolescents over 16 years, we actually have a much lower threshold of 50, and you're going to use that MDRD formula that's printed on your NHLS result. Just notice that we can't use the formulas with pregnant women. Remember, there's now baby in tow and fluid. And so there we actually use an absolute creatinine level. It's the only cases where we do. They're all women. They're all within a certain age group. So that sort of works. And we want that creatinine to be less than 85. And that's important when we're going to talk about PMTCT. But this is sometimes people forget. So sometimes we think that GFR is all about, it has to be over 16, it's normal. And that's not true. It's just more difficult to measure exactly if it's over 60. So I just want you to show you here, this is the phases, the stages of kidney disease. And a normal GFR should actually be well over 90 with no proteinuria. Then we can say your kidneys are working normally. But as soon as you start getting a bit of proteinuria, you're already in stage 1. And as soon as it drops under 90, between 60 and 90, you're already in stage 2 kidney disease. So just notice our threshold for using tenofovir is not a normal kidney, it's just a good enough kidney. So when a GFR is under 60, it already shows us that there's definite damage to that kidney, but it doesn't mean we have to do anything about it yet. So if you've got a patient who's got diabetes or hypertension and you notice the GFR is 58, take note that you need to control those chronic diseases better because the kidney's already taken some damage, but you don't have to change the medication in any way. Then a GFR of 50 is the threshold for tenofovir. So if the GFR is 55, we can still use tenofovir. We're just going to keep an eye. It's only when it drops under 50 that we actually cannot use tenofovir and need to replace it just to be safe. And it's also the first time we're going to be adjusting ARVs. And the only ARV actually that needs adjustment until the GFR is very low is your lamivudine to 150 milligrams a day. And I think even that is, they're saying one can make the threshold even lower. But just notice this. The adjustment threshold for adjusting your TB treatment is under 30. So if, especially with our MDR patients, but also with your patients on Refer4, if they've got a GFR of 38 or 42, you can still put them on the normal dosing of Refer4 for weight. It's only once it drops under 30 that you need to start adjusting your PZA and your ethambutol dosing. Do use your medicine information center, that lovely number in Cape Town, if you want to double check what you have to adjust and when. So the medicine information center, if you go to their website, you can download these lovely posters. This is from one of their posters. And you can see here, most of our drugs, certainly the ones we use commonly, we don't have to adjust with a GFR between 10 and 50. The only one there is lamivudine at 150 milligrams daily. So, and tenofovir is the only one which we then don't like to use. So some of my key principles, therefore, with renal is always make a diagnosis. Ask yourself first, is this an AKI? That's your first, is this patient dehydrated? Is he septic? If they're very malnutrition, you can't tell if they are dehydrated, and often the creatinine is up a bit. Secondly, might this be chronic kidney disease due to somebody else? Do a lipogram, check that blood pressure, look for diabetes. Quite often there's other much more prevalent reasons of why that creatinine is going up. And only then can you start thinking about the weird and wonderful like HIVAN. So that's a condition we see in patients who has had HIV for a long time. They're not yet on ARVs. They usually have got quite a lot of proteinuria. You'll have a history of a creatinine that's been up for a while. And with ARVs, they usually improve beautifully. And then, of course, I'm not covering all those rare and unrelated renal conditions like glomerulonephritis. Do a urine dipstick. If there's a lot of proteinuria, you might need to do a renal ultrasound and investigate further. So that's like a very quick diagnostic thinking process you want to go through when you see that creatinine. So I'm going to go through my 3 scenarios. Don't worry, it's going to be very quick. It's just for you to understand the principles. So now if I've got that patient who's come in, he's 56 years old, he's got diabetes, he's got hypertension, I need to start him on ARVs. Now the creatinine comes back as 124, the GFR is 46. You can see his HbA1c there is 9.2%, but CD4 is quite well. He's got a CD4 of 522. The first thing I'm worried about is maybe this is chronic renal failure due to his diabetes, or it may just be an AKI because of his HIV. HIVAN is unlikely because of that CD4, and I'll do a dipsticks to look and see what else might be going on. But in a patient like that, because the GFR is under 50, I can't start him on tenofovir. So I'm going to start him on a Bacava 3TC, remember that adjusted dose, and Dolly Tag. So that's the alternative regimen. But he doesn't have to stay on that forever. You're going to do your lipogram, you're going to check if there's protein in the urine, you're going to address the blood pressure and the sugar and what might be causing this creatinine to be up. And within a month, you want to recheck your creatinine. So one of the problems we have is that nurses put patients on these regimens and then leave them on that, even on the reduced lamivudine dosing. And meanwhile, their kidneys have recovered beautifully. If the GFR is over 50, it doesn't have to be normal, just over 50, and your patient's otherwise all right, you can do a straight switch to TLD. So within the first 3 months, it's easy to go from whatever regimen you've started to your dolutegravir-based regimen. My second scenario is now a patient who you've started on TLD 4 months ago and now he's sick. He comes in COVID or flu or gastro or whatever it might be, quite often the iris. And now you do the creatinine is 185, the EGFR is 42, and you look back and his baseline creatinine was 85. So let's assume the patient's not in ICU, he's not deadly ill with a COVID, he's just sick. Most likely he's got an AKI. So most likely he's just got an assault on his kidneys from either being dehydrated, if he's been having a fever, maybe he's not been drinking possibly, maybe he's got another infection, or we have tenofovir nephrotoxicity in the back of our mind. The first thing we're going to do in hospital is we're going to stabilize and rehydrate that patient. Because the GFR is 42, while we do it, we'll probably switch him to that abacavir, 3TC, and dolutegravir regimen. But once you've stabilized him, check what his creatinine is. Now the creatinine has dropped down to 97, the GFR is over 58. We're quite sure this was probably not caused by tenofovir. We've got enough other evidence of why that creatinine was up. And because the diagnosis was established, we're going to safely switch that patient back to DLD, and you might just keep an eye on the creatinine just to make sure you didn't get fooled by a false AKI. But just also notice that the baseline creatinine was 85, right? And the GFR now is 97. So from the time the patient started on ARVs, that creatinine has, oh, sorry, not the GFR, the creatinine, spelling mistake. The creatinine has moved up from 85 to 97. And that's probably due to the dolutegravir. That's just influenced this, this excretion. So an increase of less than 15% is completely acceptable. And even though he's got a higher GFR, a higher creatinine, sorry, we are not going to worry about that. And then my third scenario, which is now the healthy patient, be on TLD for a year, you do your routine creatinine check on a year like you're supposed to, and now you find, oh, the creatinine is 132, the GFR is 46, he had a baseline creatinine of 76, that's much more than a 15% increase, he's otherwise no other comorbidities, he's a healthy young guy, viral is fine, CD4 is fine, and now we're getting a bit nervous, could this be tenofovir related? You check that there's no other comorbidities, you don't find a clear cause, his HIV is completely stable. What's helpful is you can do a calcium and phosphate, and if that's low, then it's very likely to be tenofovir. It causes like a Fanconi-like syndrome. I haven't seen many of those, that's in the books, but it doesn't mean that if the calcium and phosphate is normal, that it's not tenofovir. So you have to look at the whole picture. And that increase of creatinine is definitely more than 15%. And because that GFR is under 50, you definitely now want to switch that patient to abacavir. Again, you're going to adjust your 3TC and the dolutegravir. So in these cases, we're not usually going to re-challenge the tenofovir. You do want to keep an eye on your creatinine. And as the creatinine goes up, if the GFR goes over 50, you want to bring your 3TC back to a normal dosing, but probably the patient will stay on abacavir, 3TC, and dolutegravir. The only complication will be if your patient is hepatitis B positive. And in a guy like that, one doesn't have, you don't have creatinins, regular creatinins. You don't know what actually happened to his creatinine over that year. And you might have a scenario like that where you decide with his hepatitis B, I think it will be good to re-challenge the tenofovir. And then you would just very carefully watch that creatinine if you do decide to try and use it. That's not in the guidelines. That's just a recommendation, as it's a question that comes up quite often. Great. So now is a good time to ask any questions specifically around renal and dolutegravir. And I might go to the chat as well now and just see if there's questions there. Okay, there's no hands that I can see. Okay, great. Oh, good. I'm just going through the chat here. Thanks, everybody. For those of you that's not yet told us who you are, please do add to the chat your name, where you work, where you're from. And if you want the link to this presentation, you just send me your email address. Okay, so there's already been the question about the fancy new diabetic treatments. As we say, we've not been reported yet. Only metformin is the only one that needs to be adjusted. So in female teenagers, so here's a good question. Would you start TEE in anticipation of her going into her reproductive years? So when the guidelines initially came out, the first time they brought out the ARV guidelines, it was said that all women with in childbearing age, which would include your teenagers, you would not use dolutegravir. The emphasis has changed. So as the guidelines is now, as the new information has come out that the risk is so low, the idea is that you counsel, but you start TEE if you have to counsel the adolescent that there's a very small risk and that if she eventually wants to fall pregnant, she must just come back in. I always say to my patients, the research is still ongoing because there's a good chance that by the time they want to fall pregnant, we already have enough confirmation that dolutegravir is safe. But if they're not planning to fall pregnant at the moment, you can still use dolutegravir as long as you do your counseling and recording. It's only when the woman says, I want to fall pregnant, where you would probably much more seriously consider in that scenario to use TEE. And I think with the teenagers, we like the TLD because it's so hard to break. So the idea is because of the resistance risk. So a new TB patient, I assume Dr. Jamal, hi, welcome. I assume you meant TB patient. So the guidelines recommend we need to start the TEEs. And that's because the dolutegravir is a twice-a-day dosing. That's the only reason the dolutegravir works as well. And if people are on a dolutegravir-based regimen and they get TB, you don't switch them. You just add in an extra 50 milligrams of the dolutegravir. So the guideline at the moment is recommending, just for the ease of use, to start the efavirenz-based regimens for TB patients. And I must say we've used it safely for very, very many years, TEE. I think we sometimes forget with the excitement with dolutegravir that TEE has been a lovely regimen, and most of our patients actually do very well on it, including our TB patients. So I'm still using it quite happily with my drug-sensitive TB patients. And then the drug-resistant ones, we all give TLD. Okay, great. And there's a yes. So there's just another reminder here for our drug-resistant TB patients. So drug-resistant TB, there's for those of you that's interested, there's a whole a few online sessions on my YouTube channel. There's one specifically on adverse events and DRTB, and it specifically covers anemia. So one of our issues is when we start drug-resistant TB patients on their regimens, they all get linezolid, and linezolid can cause bone marrow suppression, and therefore we cannot use AZT in those patients. So what we do is when we start our DRTB patients, if they are on AZT 3-DC dolutegravir, that AZT will temporarily have to be switched to denal. Well, what we normally do is we use an Aliluvia-based regimen, and then once they come off the linezolid, then we put them back on their old regimens. That's quite complicated. I don't want to confuse people. Please do send me an email if you want me to send you that specific presentation as well as the handouts on what we do with ARVs and drug-resistant TB treatment. It gets quite finicky. Well, thank you very much. Some excellent questions. I'm just going to check if there's any more hands. No, that's great. I want to have a last slide just to talk about those of you that's thinking about doing the diploma of HIV management. I have to declare my special interest here. So I am the convener of the diploma in HIV management, and I've been tasked with taking it into a new era. It sounds very posh, but what's happened is the original diploma used to be written by the infectious disease guys. So it's always fallen under family medicine. If you want to go and find out about the diploma, you go to the college website, the College of Medicine website. You go to family medicine, and then you'll find the diploma of HIV medicine underneath there. But it was originally started by infectious disease guys like Francois Venter and Prof. Meintjes, and they wanted an exam to get your primary health, secondary care doctors to really engage with HIV and get to know HIV. And in those days, HIV was still run by doctors in these very centralized clinics. And then over the years, they were the guys who always set the exam every year. And then about a year ago now, it was handed over, well, a year ago exactly, it was handed over to family medicine, and I've been the one that's sort of taken over the reins from Dr. John Black, who's been the amazing convener of it for many years before that. Well, what's also happening is the college is changing all their exams to become more and more reliable. And so the diploma has changed and will change some more in the future. The biggest thing that's happened is it used to have a short question answer paper, which has fallen away. And it's now just two MCQ papers. And eventually we might add a portfolio in, but for a knowledge-based exam, we have really upgraded the standard of our MCQs. And the one paper is standard MCQs, like in you choose best option out of 4. And then we have one that's data interpretation. So that's a bit like a OSCE, what they used to call the OSCE, but it's not an OSCE because it's the MCQ. But there's pictures, there's photographs or of rashes, there's lab results, there's x-rays, and then you get asked a question which you answer as an MCQ from there. What's amazing about the Diploma of HIV Management is it's open across all disciplines. I think it's the most popular diploma of all the diplomas. We've got 187 enrolled to right now in March. Not everybody always writes after sometimes they need to hand over to the next one, but that's, I think, a record number that's written, probably because one of the sittings was missed because of COVID. And you can be a GP, you can be a district hospital doctor, you can be working in ENT or orthopedics, or it doesn't matter where you are in medicine, we're all seeing HIV. And doing the diploma just gives you a really solid basis in understanding both the ARV side, but also just the management of the OIs, etc. So I think it's a fun diploma to do. And you prepare through self-study. So there are some fancy courses that one can do. And myself and John is quite keen to make more and more material available online. I've already got some material online to help people prepare for the diploma. But you read your guidelines, you work your way through a textbook. We've put together a very good curriculum that you can work through. And once you finish your ComServe year, it's really something that's worthwhile to engage in and to do, and it will give you a real solid basis no matter where you end up in medicine one day. So there's just my reference. You can find those in the HIV Clinician Society. You can find them all over the website if you search for them, but the HIV Clinician Society is a very good website for all of the different guidelines. For those of you who are keen to join our Rural Onboarding program, there's my email address, or you can WhatsApp me, and I can send you a link for our registration form. Please, again, for today, there's no attendance register, so please, before you leave, do just write who you are, where you're from, what you are doing, and if you want me to add you to a database, just your email address. I've definitely said everything I needed to say. I'm going to check if there's any last urgent questions. Okay, great. So somebody's asking about TLD and pregnancy. We covered that in the beginning of the presentation, but you might have missed that. So please do go back to that. At the moment, the risk is about falling pregnant. It's completely safe in the first trimester once you pass the first 6 weeks. It only has a potential effect on the neural tube development, and that's very small, and particularly if there's no folate supplementation. So in all of the studies where women had taken folate when they've fallen pregnant of dolutegravir, there was not an increased rate of neural tube defect. So I think that's quite important as well. If you do put somebody who's going to conceive on dolutegravir, just put them on some folate as well. But certainly if you diagnose them during first trimester, then just keep them on the TLD. Gosh, guys, I hope that wasn't too dry. HIV does feel like it's very programmatic, and I hope there's been you've learned the odd little thing that you might not have known you didn't know. For the next big Zoom session is on Wednesday. I'll be sending links around. If you get onto my databases, just send me an email. That's part of the Worcester Family Medicine series. Dr. Dave Stead is going to be doing something on urology and sepsis and antibiotic stewardship. That's going to be on 1 o'clock on Wednesday. If you can't make it, don't worry, we'll record it and it will be available. And then for those on the Rural Onboarding program, I'm going to send up maybe tonight, early tomorrow morning, I'll send you all the obstetric links. I've got a great ESMO-E course that you can do. I've got a great video on obstetric ultrasound that we'll send around. You can look at your obstetric PMTCT guidelines this week. And then next week on Monday night, Dr. Mondondo, our amazing DCST superhero, local hero obstetrician, is going to answer all your frequently asked questions. She will have a very good on the kinds of things that she thinks rural doctors need to know about maternal health. And then we'll send you some. There's also next week, Wednesday, there's going to be a great Zoom session from WUSU on obstetric spinal anesthesia. So also please, if you want to get onto any of those, want to know about those Zoom sessions and you're not yet on any of my databases, please send me your email address. Thank you very much, everybody. I'm going to close the session now. I'll sit on here for a couple of minutes to give people time to also put all their details on the chat. Otherwise, have a lovely dinner.